Assalamu alaikum. I hope you can all hear me. I hope you are all well and healthy and safe. This is Dr. Fatima from Surgical 2, and we have to discuss what? Postoperative care, postoperative complications, and their management. And this is our topic for today. During this discussion, we will look at the system of postoperative care, the system of daily entries in the patient's records during this, and then how we discharge the patient. And then we'll look at the serious or common postoperative complications, their recognition and avoidance. What exactly is postoperative care and how do we define it? The definition is very simple. It is the care given to the patient or the management of a patient after a surgical procedure. And the type of postoperative care that a patient gets, it depends upon the type of surgery that the patient had, depending upon how massive or how little the procedure was, and it also depends upon the health history of the patient. This care includes care given during the immediate postoperative postoperative time. This is the care in the operating room just after surgery and in the post-anesthesia care unit. And following that, it would be in the ward that follows the time after surgery and ICU. This care will continue even after the patient has been discharged and when he comes for follow-up visits to the outpatient department. Even then, instructions and care process will continue until the patient is completely healed. The aim of this postoperative care, it is to make sure that the patient has a quick, painless, and safe recovery from surgery, right? Postoperative orders and notes. This is the first step of postoperative care. It starts in the operating room. When the surgery finishes, the surgeon or the assistant, he writes down operation notes and he also adds to it postoperative care notes. These include instructions regarding the monitoring of vital signs, pain control, rate and type of IV fluid, this and that. So for vital signs, for example, the patient would write down that to monitor the vital signs, pulse, blood pressure, every half an hour for 6 hours or 12 hours, depending upon the type of the surgery patient underwent. And for pain control, a suitable analgesic, preferably an opioid or a non-steroidal anti-inflammatory agent would be added right there in the operation notes, right? The surgeon would also put down the type of fluid that he wants the patient to have and would give instructions about intake and output monitoring. All the other medications, for example, antibiotics, antiemetics, and stuff that he wants done in the postoperative area would be put down on the operation notes, right? And the patient is shifted out of the OT into the recovery area with all these instructions written on his file. In the recovery, if the patient is restless, something is wrong. You should never take for granted the fact if the patient might be restless just because he has undergone surgery. There would always be a reason for a patient being restless. It could be airway obstruction, hypoxia, hemorrhage, external, hypo or hypertension, postoperative pain, which is a very, very common reason. There may be shivering or hypothermia. There may be vomiting, and aspiration vomiting particularly is one of the most common and simple complications after surgery. This is a GI complication. Although it involves the GI tract, it is not directly related to the GI tract. It's usually because of effect of anesthesia on the gastrointestinal tract. Nothing is actually wrong with the gastrointestinal tract. There might actually be falling in the floor if the patient is not fully in control of himself. and there may be residual sleepiness and stupor. So these things, they have to be taken into account. Patient has to keep the nursing staff and the doctors, they have to keep a look out for these signs in a patient. Once the patient is wide awake, opens eyes on command, is opening eyes spontaneously, has definitely been extubated. Blood pressure and pulse are satisfactory. When you ask the patient to lift his head, he lifts his head. If the pulse oximeter, when the pulse oximeter shows you the patient is not hypoxic, breathing is quiet and comfortable, and the patient is not complaining of pain, suitable anesthesia has been given, an alert patient who's well in control of himself, then the patient is shifted from the recovery to the ward. In the ward, the aftercare would include an early mobilization. You would encourage the patient to breathe deep, encourage coughing. Daily exercise is important, joint range movement, muscular strengthening. If need be, if it's an older person or if there is a need, then walkers or crutches maybe have to be provided so that the patient can move around as quickly as possible. Attention also has to be given to adequate nutrition and skincare. If it's an old patient who finds it difficult to move, or a bulky patient who's finding it difficult to move in the bed, have to make sure the patient is turned frequently and his skin and garments are not soiled. They should not be wet. Yeah, to ensure that there is no skin breakdown that will result to pressure sores or anything of the sort. And all through this, adequate pain control is most important. You know, pain is the one thing which makes the whole experience of undergoing an operation either a torture for the patient for the rest of his life. Yeah, he will remember this incident, this part of his life, as a bad incident, a bad experience if there was pain in it. And if you keep a good control of the pain, the patient would remember this as an okay kind of an experience. Okay, then all these things that we are doing and the monitoring that we are done, they have to be recorded regularly on a daily basis. Okay? A comment on medical and nursing observations means that you have to put down in your notes at least a little bit about how the patient is doing. You would write down something like the patient is sitting comfortably in the bed, or the patient is complaining of something, the patient is complaining of pain or constipation or whatever, right? You have to write that down. Plus, you have to take a look at the wound and add a comment about the wound. The wound is clean, the dressing is dry, wound is healthy, something like that. And any complications, if there are any. For example, there is more blood in the drain or a lot of serum in the drain or something like that. And any changes that you make in the treatment according to the conditions of the patient, they all have to be recorded very systematically on a daily basis. Then when the patient gets better and has to be discharged, you give him a discharge slip and record in that the diagnosis at the time of admission and discharge, summary of the entire lot of events, the pre-op care, the operative treatment, and the post-op care that the patient had in the hospital. Then you also give instructions about further management. Okay? A copy of this is given to the patient, and you have to tell the patient when he has to come back for follow-up. Now we come to post-op complications. This was a brief summary of the things, the post-operative care manual that a patient goes through during the course of surgery. Okay, post-operative complications. How do we define that? Definition is fairly simple. All expected or unexpected adverse events from after leaving the operation theater are called or are known as post-operative complications. General risk factors for post-op complications, like most risk factors for everything, involves the extremes of ages, obesity, smoking, comorbid conditions like diabetes, other metabolic conditions, right? If drug therapy like steroids, immunosuppressants, antibiotics, contraceptive pill, वगैरह वगैरह. classification. It's not really a classification, it's more of, well, categorizing. Complications may be due to anesthesia, or they may be due to the surgery itself. And those due to surgery, they are usually divided into immediate and late, early and late, and or they can be subcategorized according to the system involved. Complications usually associated with anesthesia administration. They can start with the pinprick, right? When with the first introduction of infusion monitoring, where that there may be something simple like phlebitis, and this would not show up immediately, but this would happen in the longer run. Or there may be finger necrosis if a vasoconstrictor agent is added or inappropriately administered, and it could be something like air embolism. This, depending upon the amount of the air, can be absolutely negligible or nothing to bother about, or it can actually lead to disastrous consequences if the amount of air is massive. You can see here large air bubbles present in the pulmonary vein and here in the larger arteries. Other anesthesia complications depend upon the mode of an administration of anesthesia. This depending upon whether it was general anesthesia or regional or local, or it would depend upon the type of anesthetic agent, ठीक है? Toxicity, allergy, या जो भी, yeah, upon the mode of administration, yeah, the type of the agent itself. Local anesthesia में at the site of injection, there would be pain, hematoma, nerve trauma, or if vasoconstrictor agents like adrenaline have been added to the local anesthetic, it could lead to ischemic necrosis, especially in the nose, fingers, penis, scrotum, ears, and toes. ये वो जगह हैं which have an end arterial system with no collaterals. In जगहों पे it is absolutely contraindicated to use adrenaline or any vasoconstrictor agent along with your local anesthetic, right? In addition to this, allergic reactions, your toxicity can also occur. These would be something that would affect 1 in a million person. Then we come to spinal and epidural and caudal anesthetic agents. ये आपने अपने anesthesia के lecture में काफ़ी detail में भी पढ़ा होगा, लेकिन namely जो common complications associated with these things are technical failure, headache, which is fairly common, fairly common, intrathecal bleeding, permanent nerve or spinal cord damage, paraspinal infection, severe hypertension. And the commonest is the headache and severe hypertension. This can occur for sure. The rest are less common. Urinary retention also occurs in many people. Then we come to general anesthesia and complications that can happen during the administration of general anesthesia. Can be a direct trauma to the mouth or the pharynx, or could be related to the drug interactions or inappropriate dosage, your choice of drug, or it could be due to hypothermia, when a lot of cold fluids or cold blood is infused into the patient, and as a result of that, the patient develops hypothermia. Okay, then one specific complication of anesthesia is malignant hyperthermia. This is a condition, it's a familial condition in which the patient is sensitive to anesthesia agents, particularly succinylcholine, right? And as a result of use of succinylcholine, there would be high temperature and tachycardia and tachypnea. This would be to an extent that there would be acidosis and rigid muscles and even rhabdomyolysis if this thing goes uncontrolled. इसकी treatment के लिए you have to discontinue the anesthesia immediately, wrap the patient in cooling blanket, or benzodiazepines are given. और dentalin sulfate ये है succinylcholine का direct antidote, because this is the last thing to be given. ये तमाम काम उससे पहले करने होते हैं. Then there could be allergic reactions, or this could be a minor, जिसमें post-operative nausea and vomiting है, which is a fairly common occurrence, and the major occurrences are quite uncommon. So we come to complications due to surgery itself. ठीक है, और यहाँ पे हम देख रहे हैं these complications being categorized according to the systems of the body. ठीक है, respiratory complications, they are very common. They include atelectasis, pneumonia, pulmonary embolism, वगैरह वगैरह वगैरह. Urinary complications like urinary retention or UTI, and gastrointestinal complications, for example, paralytic ileus, which is fairly common. ठीक है? We will look at most of them in greater detail in a little bit. Ye complications can also be classified according to how soon or late after the surgery they appear. Immediate complications usually जो between right after surgery to up to 24 hours, इनमें जो सबसे commonest हैं वो हैं primary hemorrhage, basal atelectasis or shock, and this would be due to another type of hemorrhage. We'll come to that. Early, within two days to about 3 weeks. इसमें है mental change, fever, secondary hemorrhage, wound infection, paralytic ileus. So जो late हैं like bowel obstruction, incisional hernia वगैरह वगैरह. Whenever there is a complication, this is the basic scheme that one has to follow to manage it. ठीक है? सबसे पहले immediate management, ABCD, is the first thing to do. एक दफ़ा patient has been sort of stabilized, then you look into the entire chart, history, examination, and go over the entire history of the patient one more time to see कि कहाँ पे lapse हो गया है, किस वजह से complication हो गई है, ठीक है? जब आपको ये चीज़ एक दफ़ा आप रिव्यू कर लेते हो तो देन यू डिसाइड एंड प्लान. अगर तो पेशेंट को आपने स्टेबलाइज कर दिया है और वो स्टेबल ही है तो यू कैन कंटिन्यू विद नॉर्मल ट्रीटमेंट. ठीक है, अगर पेशेंट अभी भी अनस्टेबल है एंड यू अनश्योर ऑफ डायग्नोसिस तो फिर आपको स्पेसिफिक किस्म की इन्वेस्टिगेशंस करनी होंगी. फॉर एग्जांपल एंडोस्कोपी और समथिंग इन केस देयर इज अ ब्लीडिंग ऑफ सम सॉर्ट. ठीक है, और अगर आपके पास डायग्नोसिस श्योर शॉर्ट है लेकिन पेशेंट अनस्टेबल है तो फिर डेफिनेटिव केयर इज अ मस्ट. फॉर एग्जांपल अगर आपको पता चल गया है कि पेशेंट अंदर ब्लीड कर रहा है तो यू विल गो फॉर अ लेप्रोटमी राइट अवे, राइट? ओके, ये हैं डिफरेंट कॉम्प्लिकेशंस. सबसे पहले लेट्स सी इफ देयर इज लो ब्लड प्रेशर पोस्ट ऑपरेटिवली और यू फियर कि द पेशेंट इज गोइंग इनटू अ हाइपोवोलेमिक शॉक ऑफ सम सॉर्ट. तो you have to decide कि किस वजह से हो रहा है. Is the patient dehydrated? This can be checked and किस तरह पता चलेगा ये? यहाँ पे जो indicator हमें सबसे ज़्यादा help करेगा that would be the urine output of the patient, the skin temperature, you look at the tongue of the patient, and simple fluid replacement will serve our cause, right? If the patient has had an epidural anesthetic and has low blood pressure because of that, यहाँ पे भी simple fluid replacement से और at times vasopressor agents की मदद से you can stabilize the patient. Is the patient losing blood? Is the low blood pressure because of bleeding? That can be a really serious issue. ठीक है? This can actually kill the patient. You have to start by giving the patient fluid and blood transfusions, and if need be, remove the cause, even if it entails reopening the patient. If there has been too much morphine, so it has to be antidoted. एक major concern in older patients, or especially who already have a history of this, is this particular occurrence, and an immediate ECG will direct you in the correct direction. Okay. अब यही जो हम अभी देख रहे हैं, पेशेंट अगर ब्लीड कर रहा है और उसकी वजह से देयर इज हाइपोटेंशन और मे बी देयर इज नो हाइपोटेंशन मगर द पेशेंट इज ब्लीडिंग. टाइप ऑफ हेमरेजेस, primary hemorrhage is the one which occurs at the table, which is caused during the course of surgery. ठीक है, वो हो सकता है कि उसी वक्त पता चल जाए and can be dealt with right then, और मुमकिन है कि वो उस वक्त मिस हो जाए. ठीक है, बाद में पता चले, which is obviously more difficult to deal with. लेकिन this occurs during the course of surgery, right? Inadequate hemostasis की वजह से unrecognized damage to a blood vessel, defective vascular stenosis वगैरह वगैरह, clotting factor deficiency. और इसके लिए अगर वो उसी वक्त पता चल जाता है तो इट हैज़ बी टू बी डेल्ट विद राइट देन, और अगर बाद में पता चलता है तो इट पेशेंट हैज़ टू बी री एक्सप्लोर्ड, रीओपन्ड एंड डेल्ट विद. Then there is secondary hemorrhage. This is usually related to infection. ये कब होता है? This would happen like 5 to 10 days after surgery. ये क्यों होगा? जब इन्फेक्शन के नतीजे में देर इज स्लफिंग ऑफ टिश्यूज एंड तमाम वो जो लिगेचर वगैरह आपने अच्छी तरह कस के लगाए थे उनमें से कोई लिगेचर ही स्लफ हो जाता है, या जो भी आपने कंट्रोल लगाया था वो स्लफ ऑफ हो गया है इन्फेक्शन के नतीजे में, उसके नतीजे में जो हेमरेज होगा दैट इज अ सेकेंडरी हेमरेज. ओके, नाउ व्हाट्स अ रिएक्शनरी हेमरेज? Wow, this is supposed to be the tummy of a patient like say 14-15 hours after a laparoscopic cholecystectomy or something, some sort of surgery. Okay, इसमें आप देख रहे हो कि the entire skin is blotched up. There is staining of the skin because of the underlying hemorrhage. ठीक है, this indicates a reactionary hemorrhage. Define इसे कैसे करेंगे? It occurs within 24 hours and it is caused by dislodgement of a clot during resuscitation when the blood pressure of the patient normalizes after the effects of anesthesia wears off. Okay, and there is vasodilatation. When the blood pressure rises, then as a result of that, some of the bleeding which could not be obvious during the course of surgery, it becomes prominent. ठीक है, सर्जरी में क्योंकि के दरमियान जब ब्लड प्रेशर एनेस्थीसिया के इफेक्ट की वजह से कम था तो द वेसल यू कुड नॉट सी एनी ब्लीडिंग, लेकिन बाद में जब बीपी नॉर्मल हो जाए तो वही ब्लीडिंग जो सब कुछ नज़र नहीं आ रही थी वो ज़्यादा होनी शुरू हो जाती है. इट कैन ऑल्सो रिजल्ट फ्रॉम टेक्निकल फेलियर सच एज स्लिपेज ऑफ फोलिक एसिड. जब बीपी ज़्यादा हुआ तो उसके नतीजे में एक नॉट जो ढीली थी या एक क्लिप जो ढीला था वो उतर गया. राइट, करेंगे क्या हम इसका? ट्रांसफ्यूज, यस. Fluids, yes. ठीक है, then you will examine the wound of the patient. अगर तो obvious external bleeding है तो pressure dressing can do the job. ठीक है, उससे वो control हो जाएगा. लेकिन अगर intrinsic bleeding है, अंदर है, बाहर कुछ नजर नहीं आ रहा, तो फिर you will obviously have to reopen the patient. Next we come to hypothermia. This is basically a result of general anesthesia and during and even surgery. एक तो anesthesia की वजह से there is general deregulation of the body temperature, right? And उसके नतीजे में the body temperature falls down. Plus cool fluids, अगर properly warmed fluids नहीं दिए गए वो, plus irrigation. Suppose like laparotomy हुई है, आप peritoneal lavage कर रहे हो, wash कर रहे हो, और वो fluid wash जो है वो गर्म नहीं है, तो उन इस किस्म की सिचुएशन में, या अगर आप बड़ा सारा वूंड है उसको वॉश कर रहे हैं ठंडे या पानी से, तो उसके नतीजे में द पेशेंट में गो इनटू state of hypothermia. ठीक है, and this is really bad because it can lead to coagulopathy and platelet dysfunction and increased oxygen consumption due to shivering. You know, this does form the deadly triad if you don't deal with it immediately. करना क्या है हमने? Use warmers like forced air blankets, something like this. जिनमें warm air is pushed into the blanket and the patient is kept warm. And then you could do some small doses of mepridine to prevent shivering. This condition when the patient obviously is shivering rapidly to generate enough body heat. After hypothermia is hyperthermia, right? Postoperative fever. Body temperature greater than 38 degrees, 38.5 degrees centigrade. Occurs in about 40% of people, yes, a majority of people. And उनमें खुद ही ये आराम से एक आध दिन में ठीक भी हो जाता है. It's not really a big deal after surgery. But if it continues or if it is unusual, if it is unusually high, so it has to be looked into. The causes of postoperative fever, they can usually be divided according to their appearance in the on the timeline. जो पहले 2 दिनों के अंदर within 24 hours fever होता है, it is usually due to basal atelectasis, right? जो after 48 hours है, that is usually due to UTI, a urinary tract infection, या IV catheter related phlebitis, या something like pneumonia showing up. जो 5th day के बाद होती हैं fever, फीवर होता है उसकी जो वजह है दैट इज़ वुंड इन्फेक्शन, कॉमनेस्ट वजह, एनास्टोमोटिक ब्रेकडाउन इफ देयर हैज़ बीन गैस्ट्रोइंटेस्टाइनल सर्जरी, or there may be an intra-abdominal abscess, और जो पूरे हफ्ते के बाद या after the 7th day you usually have fever due to deep vein thrombosis and pulmonary embolism. How do you work up this? Usual चीज़ें, complete blood count, blood culture, urine analysis, x-ray chest, sputum culture वगैरह वगैरह. Treatment इसकी symptomatic, आपने fever को treat करना है with an antipyretic, namely क्या, something like Panadol, right? Or definite treatment या treatment of the cause अगर आपको when you get a clear indication into the cause, underlying cause. Then we come to wound complications. Wound complications में the commonest complication is infection, which may be superficial or deep or space infection or neither. Or depending upon the system or the type of surgery that the patient underwent, the causes may be staph in thoracic surgery and neurovascular surgery, जहाँ पे भी external kind of surgery, or gram-negative bacteria for GI surgery and urological surgery, and strep in head and neck surgery, ठीक है, ENT type of surgery. करना क्या है इसका? Superficial चीज़ को incision and drainage without systemic antibiotic. If it is deeper, then surgical debridement plus systemic antibiotic. Or if there is a space, underlying body cavity space, से मुराद है underlying body cavity like the peritoneum or the pleural cavity, whatever, they are involved, तो फिर percutaneous drainage या open drainage according to the requirement. Okay, what is this? Hematoma. This could either be a hematoma or a seroma. दोनों में क्या फ़र्क है? Localized collection of blood, localized collection of serous fluid. इसमें commonest sites वो हैं जहाँ पे ज़्यादा dissection की जाती है subcutaneous plane में. Breast and abdominal surgery, ठीक है? Hematoma को क्या करेंगे? If it is tiny, तो it will absorb spontaneously unless it is in some place like this, और अगर वो tight है तो it can cause a respiratory compromise. उस सूरत में आपको इसको खोलना पड़ेगा. If it is large, it will need drainage. Same goes for seroma. If it is tiny, तो वो spontaneously absorb हो जाएगा, और otherwise surgical drainage. Next wound complication is wound dehiscence. Wound dehiscence का क्या मतलब है? Means when the wound does not heal, और जब आप टांके निकालते हैं, when you remove the stitches, the wound simply gives way. It can actually happen even in the presence of stitches. It won't open completely, लेकिन आप यहाँ देख रहे हैं कि there is absolutely no effort at healing by the body. क्यों? Risk factors, general and local as usual. General में वही तमाम चीज़ें, malnourishment, diabetes, obesity, renal failure, jaundice वगैरह वगैरह वगैरह. और local में inadequate, poor closure, ठीक है? Poor wound healing because of infection, and increased intra-abdominal pressure in case of abdominal wounds, excessive coughing and stuff. Okay, करेंगे क्या? Or we will have to simply stitch things back. Take the patient back to the OT and stitch him up. Okay. अब यही जो हमने wound dehiscence अभी देखा है, ये इसको अगर हम फौरी तौर पे सुपरफिशियली सी देते हैं, ठीक है, सिर्फ अगर हम स्किन को सी दें इस पेशेंट को तो ये हो जाएगा. अगर हम नीचे पूरे मसल्स को इन्फेक्शन की वजह से किसी वजह से प्रॉपर्ली क्लोज नहीं कर पाते, सिर्फ स्किन क्लोज हो जाती है या इन्फेक्शन के नतीजे में जो मसल्स हैं दे गिव वे मगर द स्किन इज इंटैक्ट, तो द रिजल्ट इज एन इंसिजनल हर्निया, राइट. दिस इज अ लॉन्ग टर्म कॉम्प्लिकेशन एंड इसका जो है ट्रीटमेंट दैट वुड बी preferably a mesh hernioplasty, when you will have to insert a mesh and stitch up the condition, right? Okay, next up is respiratory complications. ये हैं airway obstruction, atelectasis, aspiration, pneumonias, pulmonary embolism, या pneumothorax, ठीक है? All these things can occur after surgery. Causes of hypoxia. ठीक है. एयरवे ऑब्स्ट्रक्शन सबसे पहले किस वजह से होती है एयरवे ऑब्स्ट्रक्शन आफ्टर सर्जरी? Due to residual effect of general anesthesia, the patient is too stuporosed. When patient is lying flat, the tongue falls back, or there would be secretions collected in the pharynx and they have not been cleared by the anesthetic completely, or there are more secretions that have collected after the surgery. Plus, there could be a wound hematoma after neck surgery, जिसकी हमने भी पहली बात की है. Yes, something like this. अगर ये खौफनाक किस्म का hematoma बन गया हो, they will have to open it up. Otherwise, it can simply press on the trachea and put the patient into a respiratory compromised situation. ठीक है? Other than this, obstruction could be due to laryngeal edema, due to trauma during intubation, or due to recurrent nerve palsy, or could be due to hypoventilation during anesthesia. Wherever. ठीक है? Management इसकी हमने क्या करनी है? First thing, head tilt, chin lift, jaw thrust. ठीक है? This would relieve the obstruction related to reduced muscle tone, यानी tongue falling back. ठीक है? In a obviously in a flat lying patient who is kind of sleepy, this would be the first thing to do. उसके बाद you will clear the secretions, blood secretions, कुछ भी foreign body जो भी है उसके अंदर उसे clear करेंगे. Then if the patient can breathe spontaneously और उसके दोबारा intubate करने की ज़रूरत नहीं है तो मास्क के साथ उसको हम ऑक्सीजन शुरू कर देंगे 15 liters per minute के हिसाब से. This should take care of most situations. Next, and this is a very common respiratory complication of any surgery, particularly upper abdominal surgery. ठीक है? उसमें पेन की वजह से पेशेंट लंबा गहरा सांस नहीं लेता, रुक के छोटे छोटे सांस लेता है, and as a result of that, the lower part of the lung, वहाँ पे alveoli and they collapse. ठीक है? When alveoli collapse, it means that the interface between air and blood is gone, and इस जगह पे there can be no exchange of gases. It is common, 25% of patients do have that. वही के thoracic or upper abdominal surgery में it's most common, and it usually presents with fever within the first 48 hours. X-ray पे this is the kind of thing you see. आगे हम इसे compare भी करके भी देखेंगे. करना क्या है इसके लिए? Profile X's is the best thing to do. अगर स्मोकर है तो पहले से स्मोकिंग ख़त्म करवा दें और ऑपरेटिव पीरियड में और इमीडिएटली पोस्ट ऑप पीरियड में कम्प्लीटली पेन फ्री रखेंगे पेशेंट को, खुल के सांस लेगा खूब आराम से. ठीक है? अगर उसको पेन होगी हर सांस पे तो वो कभी भी आराम से सांस नहीं लेगा. इंसेंटिव स्पायरोमेट्री जिसमें ये हो गया है, डीलिंग विद इट इज इंसेंटिव स्पायरोमेट्री. ठीक है? Patient would put in effort, encourage coughing, chest physiotherapy. These are the basic things. ठीक है? This is a comparison of two X-rays, one showing fluid overload and one showing atelectasis. इसमें आप देख रहे हैं कि जो fluid overload वाला X-ray है, इसमें there's a cloudy appearance, right? Lekin on the atelectasis side, you can see a very clear-cut margin of the area of the lung which has collapsed, right? Next complication is aspiration pneumonia. ये बल्कि aspiration pneumonia से पहले just aspiration. This occurs in those patients जिसमें intubation या extubation पे कोई गड़बड़ हुई हो, when the patient is still kind of dopey. Especially वो उन लोगों में जिसमें emergency में intubation की गई हो with a full stomach. ठीक है ना? उनमें regurgitate करके aspirate करने के chances सबसे ज़्यादा होते हैं. Right? और इसमें करना क्या है? अगर ऐसा हो जाए तो फिर obviously you have to try to wash it off out with a bronchoalveolar lavage. Bronchoscopy is a must. फिर antibiotics may have to be given. This is kind of what it looks like. ये भी अभी compare करके मैं आपको दिखाती हूँ. एक simple pneumonia है. This is due to prolonged ventilatory support, when there is a source of infection in the body already, right? करना इसके लिए हमने वही है antibiotics and clearing of airways. ये है comparison between the two. This is ये है aspiration pneumonia और ये है bronchoalveolar pneumonia. आप देख रहे हो कि जो bronchoalveolar pneumonia है ना, it is more peripheral. ठीक है, जो इसमें जो सोर्स ऑफ इन्फेक्शन है, इट रीच्ड द लंग थ्रू द ब्लड स्ट्रीम, ठीक है, एंड इट यूजुअली गेट्स टू द पेरिफेरल एरियाज मोर क्विकली. यहाँ पे जो गड़बड़ है वो ब्रोंकस में से अंदर आई थी, ठीक है, द एस्पिरेटेड मटेरियल फ्रॉम द स्टमक इट केम डाउन एंड स्लिड दिस वे. इसमें जो फोकस इन्फेक्शन है, इट इज मोर सेंट्रल. दिस इज द यूजुअल डिफरेंस बिटवीन ब्रोंकोअल्वेolar एंड inspiration pneumonia x-rays. फिर there could be an incidence of pneumothorax. It is usually associated जब CVP लाइन डाल रहे हों तब उसके नतीजे में, या फिर पॉजिटिव प्रेशर वेंटिलेशन की वजह से, या फिर जब कोई thoracic सर्जरी रही हो तो उसमें तो pleura can get damaged anyhow. Yeah, this is an X-ray showing an massive kind of pneumothorax. और ये आप देख रहे हो इधर, ये वो सीवी लाइन साहब है जिसकी वजह से ये हुआ है, ठीक है. सीवी लाइन इट इंजर्ड द प्लोरा ड्यूरिंग इट्स इंसर्शन. करना क्या है, you know this very well, chest tube या thoracostomy tube. Next we come to cardiovascular complications. These obviously, as indicated by the system involved, can be life-threatening, and they can include MIs, arrhythmias, and DVT, right? MI में इनके चांसेस सबसे ज़्यादा उन लोगों में होंगे जो कि पहले ही जिनकी हिस्ट्री है, older people and those who already have a history of MI in the previous 6 months. इनमें सर्जरी करना is a big deal, right? And the people who have already had angina in ये वो. It usually presents within the first 2 to 5 days, यानी second to after 48 hours to up to 5th day, ठीक है. और it can be asymptomatic, लेकिन it can present as hypotension, arrhythmia, nausea, vomiting, and of course chest pain. Diagnosis is with ECG, और उसके creatine kinase करा लेंगे, troponin करा लेंगे. And treatment is of course with nitrates and aspirin and oxygen, pain control. ठीक है, मगर this is a possibility and should be looked into. अगर कोई patient इन चीज़ों के साथ present करता है या complain करता है post-op period में, do not rule this out. Do not go without ruling this out by getting an ECG done. Then could be arrhythmias. Arrhythmias भी उन लोगों में होते हैं जिनमें पहले से ये problem, cardiac problems are there. They are precipitated by hypokalemia and hypoxemia, alkalosis या stress after surgery, ठीक है. उन लोगों में they get precipitated. जो आमतौर पे the type of arrhythmias that are seen are atrial flutter and fibrillation. इसको usually digitalis से सबसे ज़्यादा digoxin से ही control किया जाता है या calcium channel blockers से, ठीक है. अगर patient unstable है तो फिर cardioversion की नौबत आती है. जो है VPCs या PVCs, they are usually controlled with oxygen and sedation. That gives a good result. जो ventricular tachycardia है उसके लिए lidocaine is the treatment of choice. अगर there is a heart block of some sort तो फिर pacemaker has to be inserted. Third, cardiovascular, and this is the most common cardiovascular complication which occurs in a great majority of patients, is DVT या deep vein thrombosis. इसमें रिस्क फैक्टर्स वही हैं, एडवांस एज, ओबेसिटी, इसमें हार्मोनल थेरेपी, इमोबिलाइजेशन, स्मोकिंग, दिस इज, ठीक है, ये चीज़ खास इंपॉर्टेंट है इसमें. पीपल ऑन कॉन्ट्रासेप्टिव पिल वगैरह, इसका हम मजीद भी अभी कैटेगराइजेशन देखते हैं. दे कैन बी एसिम्प्टोमेटिक इन 50% ऑफ पीपल, मगर टेंडरनेस एंड स्वेलिंग एंड पेन इन द लिम्ब would be present in the other lot, right? There still is a percentage जिसमें DVT का पता ही नहीं चलता. They directly present with signs of pulmonary embolism, which occurs after the initial DVT. Homan sign ये है कि when you move the calf, there is passive dorsiflexion of the ankle. तो उसके नतीजे में patient feels pain in the calf. इसकी जो definitive diagnosis है वो duplex scan या Doppler पे है. ये है stratification of risk factors. इसके chances DVT के they are really low with maxillofacial neurosurgery, cardiothoracic surgery, medium chances with abdominal surgery, gynecological urinary surgery, or high chances with pelvic surgery, elective या trauma हो तो super high chances with that. In total knee and hip replacement maybe there are great chances of developing a DVT. DVT के नतीजे में there could be pulmonary embolism, This is a respiratory oblique cardiovascular complication which can present with chest pain, and dyspnea, shortness of breath, is the most common of presentations of this thing. पता कैसे चलेगा? EBGs पे CT एंजियो कराना पड़ेगा, ठीक है? पल्मोनरी एंजियोग्राम अब जरा कोई कम ही कराता है, लेकिन it was considered to be the gold standard. What has happened is कि the clot has moved up the leg, up the vena cava, right, and through the heart into the pulmonary circulation, और फिर जाके it blocks any one vessel in the lung. It depending. Oops. Hello, बेटा जल्दी से आ जाओ बच्चे. ये फिर लगा दो, मेरा हाथ लगने से वो बंद हो गया है ये प्रेजेंटेशन. ओके, थैंक यू, शुक्रिया. सॉरी अबाउट द इंटरप्शन. ओके, करना हमने क्या है इनके लिए? प्रिवेंटिव मेजर्स आर द बेस्ट थिंग टू डू. प्री ऑपरेटिव हेपरिन, लो मॉलिक्यूलर वेट हेपरिन इज द चॉइस. इलास्टिक स्टॉकिंग्स, अर्ली एम्बुलेशन, ठीक है, प्रिवेंटिव मेजर्स जहाँ काम कर दें, दैट इज बेस्ट. अदरवाइज treatment when this has happened, stable patient के अंदर you will start low molecular weight heparin और फिर insert a greenfield filter जहाँ पे vena cava के अंदर a filter is applied so that clots cannot travel up the vena cava. और अगर patient unstable है तो फिर thrombolytic therapy या embolectomy. Next we shift to urinary complications जिसमें हमारे पास है acute renal failure, which is less common, obviously. Urinary retention, which is fairly common, and UTI, which is very, very common. Acute renal failure क्यों होगा? It has obviously three kind of reasons. Pre-renal में hypovolemia is one major cause. It's volemia, not volemia. Is the major cause. जहाँ पे renal causes हैं, तो nephrotoxic drugs, ठीक है, और surgery involving the renal vessels या myoglobinuria. और पोस्ट रीनल में यूरेटेरिक इंजरी या ब्लॉक्ड रीनल कैथेटर, ठीक है, यूरिनरी कैथेटर. करना हमने क्या है? द ट्रीटमेंट ऑफ एक्यूट रीनल फेलियर, यू ऑलरेडी नो दैट. ट्रीट द अंडरलाइंग कॉज और ट्रीट द कॉम्प्लिकेशंस टिल द पेशेंट रिकवर्स. जिसके लिए है बैलेंस आउट द फ्लूइड्स, टेक केयर ऑफ द पोटेशियम, रिस्टोर द कैल्शियम, एंड डायलिसिस में भी नीडेड इन पेशेंट्स जहाँ पे यूरिया और क्रिएटिनिन बहुत ज़्यादा हो जाए. तो यूरिनरी रिटेंशन, urinary retention आप देख रहे हैं this massive balloon of a thing over here. इसकी वजह क्या है? commonest वजह है blocked urinary catheter, enlarged bladder after spinal, ठीक है. अभी हमने शुरू में ही बात की थी कि spinal anesthesia के नतीजे में this is a complication of spinal anesthesia. And after urinary tract surgery, for example prostate surgery जिसमें there would be bleeding in the bladder and clots फंस के तो catheter को बंद कर देते हैं, and as a result of that there is retention. इसकी जो treatment है that is inserting a patent Foley's. अगर already मौजूद Foley's catheter urinary catheter बंद हो गया है तो उसे wash करेंगे या replace करेंगे. UTI, this is probably the commonest complication of hospital stay. Risk factors इसमें फिर urinary retention, pre-existing contamination या instrumentation जिसमें urinary tract पे ही काम हो रहा था तो वो. Symptoms, dysuria, mild fever, और अगर kidney involved है तो फिर high fever. Diagnose कैसे करेंगे? Through urinary examination and cultures, or treatment is proper drainage of the urinary bladder. If there is free flow, no nothing impeding the flow, no stones, no prostate getting in the way of urinary passage, so this thing will automatically clear, and antibiotics may be needed to aid the situation. When we come to gastrointestinal complications, nausea, vomiting की हमने पहले ही बात की थी, लेकिन वो होता है as a result of reaction to general anesthetic agent. ये वो complications हैं which are the direct result of involvement of the gastrointestinal tract, except for one, paralytic ileus. ठीक है, we'll come to this in a bit. पैरालिटिक आइलिस में क्या होता है? देयर इज पैरालिसिस ऑफ द बाउल। और होता क्यों है? दिस इज रिजल्ट ऑफ हाइपोकलीमिया या नार्कोटिक ड्रग्स आफ्टर, या फिर गैस्ट्रोइंटेस्टिनल सर्जरी। ऑब्वियसली इसमें आपने गट के साथ खूब सारी छेड़खानी की है, तो उसके नतीजे में दिस हैपेंस, इट इज एक्सपेक्टेड टू हैपन। नतीजे में उसके देयर इज कॉन्स्टिपेशन, एब्डोमिनल पेन, डिस्टेंडेड एब्डोमेन। दिस इज द काइंड ऑफ एक्सरे दैट यू सी, ऑल द बाउल इज डिस्टेंडेड। करना ट्रीटमेंट इसकी बेसिकली है व्हाट? ड्रिप एंड सक। ठीक है, ड्रिप देंगे, पेशेंट को एनपीओ कर देंगे। पेशेंट विल स्टे नथिंग पर ओरल, जितनी देर वो रिकवर नहीं कर रहा था। आईवी फ्लूइड्स से देंगे और पोटेशियम रिप्लेस करेंगे। पोटेशियम रिप्लेस होगा, एनजी डली रहेगी, गैस्ट्रोइंटेस्टिनल ट्रैक्ट जो है उसको डिकम्प्रेस करते रहेंगे। ठीक है, द रिकवरी यूजुअली टेक्स लाइक 3 to 5 days। पोटेशियम रिप्लेस हो जाता है, सारा सिस्टम डिकम्प्रेस हो जाता है एंड द गट यूजुअली स्टार्ट्स टू मूव। नेक्स्ट अप इज एनास्टोमोटिक लीकेज एंड डेरोक्टेनियस फिस्टुला। ये यूजुअली नतीजा होगा ट्रॉमा का या सर्जरी जिसमें आपने एनास्टोमोसिस किया है, और यूजुअली अराउंड 5th day और समथिंग द एनास्टोमोसिस गिव्स वे। और उसके नतीजे में वो चीज़ यहाँ पे सीटी स्कैन पे देख रहे हो कि ये गट कंटेंट्स हैं विच आर सर्फेसिंग एंड कमिंग अप टू द स्किन थ्रू अ मे बी अ ड्रेनेज साइट। ये ड्रेन साइट होगी जिससे ये सारा गैस्ट्रिक कंटेंट्स या सॉरी इंटेस्टाइनल कंटेंट्स बाहर आना शुरू हो जाएंगे। इसके लिए हमने दिस इज सीटी या फिस्टुलोग्राम इज द ट्रीटमेंट। ये सीटी है। फिस्टुलोग्राम में व्हाट यू डू इज कि आप यहीं से डाई इंजेक्ट करेंगे और एक्सरे ले लेंगे, तो उससे भी पता चल जाएगा। करना क्या है? फर्स्ट थिंग टू डू इज एनपीओ, टोटल पेरेंटल न्यूट्रिशन। ठीक है, इसके नतीजे में हाफ ऑफ द फिशलर्स विल रिजॉल्व बाय देमसेल्फ। लेकिन those fistulae that do not resolve after treatment, this conservative treatment, they will need to be reopened and reanastomosed. Pseudomembranous colitis, ये क्या है? Pseudomembranous colitis is this is kind of what it looks like. आप देख रहे हो कि exophy membrane is formed on top of the usual mucous membrane of the colon. It is caused by Clostridium difficile, or ऐसे patients who have stayed in the hospital for a longer time, या those who have taken a lot of antibiotics one after the other. Suppose से पहले जिस प्रॉब्लम के लिए आया था उसके लिए एंटीबायोटिक खाई, फिर निमोनिया हो गया, फिर उसके लिए खाई, फिर किसी और चीज़ के लिए फ्लिपाइटिस हो गया, फिर उसके लिए खाई। उसके नतीजे में द एंटायर फ्लोरा ऑफ द गट इज डिस्ट्रॉयड। ठीक है, क्लिंडामाइसिन इज सॉर्ट ऑफ नोन फॉर डूइंग दिस। नतीजे में देर इज़ डायरिया विच इज़ स्ट्रीक्ड विद ब्लड। उसके नतीजे में देर इज़ हाइपोटेंशन, टेकिकार्डिया। इसमें एक्चुअली टॉक्सिक मेगाकोलन भी हो सकता है, कोलन रप्चर भी हो सकता है जिसमें आपको फाइनली सर्जरी करनी पड़ेगी, मगर नॉर्मली इट डजंट कम टू दैट। ट्रीटमेंट इज़ विद मेट्रोनिडाजोल या फ्लैजल। ठीक है, IV or orally, this is the first line of treatment. If this doesn't work, तो vancomycin is the second line of treatment. Then another speciality related, अभी तक ये GIT में भी जो हम देख रहे थे ये speciality related complications ही थी, उसमें जो enterocutaneous fistula है। एक मजीद speciality specific complication हम orthopedics में नज़र डाल रहे हैं, इस compartment syndrome। क्या ये यूजुअली ऑर्थोपेडिक सर्जरी के बाद या ट्रॉमा के बाद जब पेशेंट आता है और उस पर सर्जरी की जाए या टाइट कास्ट वगैरह लग जाए तो उसके नतीजे में ये हो सकता है। द पेशेंट प्रेजेंट्स विद severe pain which is out of proportion to all signs available. ठीक है, when you look at the patient, you look at the limb, it looks almost fine. Okay, the patient is in agony, right? After a long time, if it goes untreated, there would be paralysis and paresthesia and pulselessness वगैरह वगैरह। करना इसके लिए क्या, you all already know this very well, decompression करनी है, तमाम पट्टियाँ कपड़े शपड़े इसके ऊपर से उतार देने हैं, and fasciotomy if need be. Then there's this other thing, sarcopenia. ये longer duration की चीज़ है. This is loss of muscle. Oops, sorry for that. Loss of muscle mass in bedridden patients who have been who have had to stay in bed for a long time. For example, after hip trauma या something जिसकी surgery नहीं हुई या fracture या something like that. अगर एक young patient is bedridden, तो he can lose up to 1% of muscle mass per day. लेकिन एक बुढ़ा बंदा can lose up to 5% of muscle mass, right? So this has to be prevented. बंदा कहाँ से कहाँ पहुँच जाता है. Mobilize the patient as early as quick as possible. ठीक है? Provide them all the walking aids which are required. Make sure that the patients walk around as quickly as possible. Or nutritional deficiencies should be avoided because they make this thing worse. फिर न्यूरोलॉजिकल कॉम्प्लिकेशंस भी हो सकते हैं, ड्रग इंड्यूस्ड साइकोसिस या आईसीयू साइकोसिस, न्यूरोसाइकेट्रिक कॉम्प्लिकेशंस, ठीक है. एंड दीज कैन बी अवॉइडेड बाय cutting down on the amount of medications that the patient is getting. जो drug induced है उसमें check the drugs that the patient is getting. और जो ICU वाले में भी you have to stop all drugs, right? And you have to consult the psychiatrist for this. Late complications हमारे पास हैं. This is the very last slide, I think. They involve hypertrophic scars. या पहले ही जानते हो सब कुछ. Keloids, when large hypertrophic scars form and they go beyond the boundaries of the wound. Then there could be a wound sinus. ये क्यों होगा? When there's a non-absorbable stitch lying at the base of the wound, something like a proline number 1, thick, stiff, non-absorbable material. It simply keeps digging into the skin and until the sinus is formed. Then implantation dermoids, छोटी मोटी fleck या छोटे से particle के इर्द गिर्द dermoid forms. Then seminal hernia हम already देख चुके हैं. Abdominal surgery के नतीजे में in the long run intestinal obstruction can result from adhesions and can even result in strangulation. फिर abdominal surgery के नतीजे में there could also be a shortcut syndrome, या पहले ही जानते हो. फिर post gastric surgery syndromes, ठीक है. And susceptibility to other diseases, for example malabsorption, इसमें आपने gut का बहुत सारा segment, particularly ileum निकाल दिया है, malabsorption, and there is also incidence of cancer, right? And this is about it, I think. Yep. Any questions? Well, thank you for your attention. Thanks a lot. If there are any questions of any sort, so that you have already gone through this lecture before, like, and if there are any questions, you're most welcome.